konuşması için Mustafa Kerem hocamız teşekkür ederiz. Sırada kendisi aslında bu aramızda olacaktı ama sağlık programları nedeniyle burada bulunamadı. Avrupa Afrika HPB Derneği Yönetim Kurulu üyesi Giovanni Marchegiani. Giovanni, can you hear us?
Yes, I do. Good morning.
Good morning, Giovanni. How are you?
I'm good, recovering. Thank you very much. I'm very sorry I couldn't make it to Bakü, but I can guarantee I'm with you to bring you the spirit of the EA-HPBA and to welcome you all within our family and our community. Can you hear me well?
Yeah. Yes, very fine.
Perfect.
I hope you will get better soon. Now we're waiting for your opening speech. Now it's your turn.
Thank you so much. So, if you can hear me well, while I'm starting with my first presentation, once again, as Professor Mustafa Kerem...
Giovanni, sorry, your presentation will be afterwards, but if you want to tell for something for the opening speech, we are listening for you.
Yes, so I would like to warmly welcome you within the EBA. This is a message in particular for the young HPV surgeon in the Trans-Caspian community, because I know my friend Mustafa Kerem since many years, and I know how vibrant the Turkish community is. I personally visited Turkey for the HPV conference several times, and I think this is the right environment to join the EA-HPBA community again, particularly for the young trainees and everyone in those countries who's willing to learn this fantastic surgery, but also to expand the borders of the community. We will meet soon in 2025 all together in Dublin, Ireland. I will show a slide regarding the official invitation. But as myself, as the chair of the membership committee, I will always do my best together with Professor Kerem to make you feel home in the community, to organize events such as webinars and other online events to provide education for your community. And I will also personally try to hear what your needs are, because we know as a huge community that those needs come with very specific requests depending on where we are. So we are a big community, but we are also very open to listen to the need of the specific chapters of our big community. So that is my promise to you, and as it is for the Turkish HPV community, which is a very big one, it's even growing more, and it's becoming one of the leading community within the European and African HPBA. That's how I feel the Trans-Caspian HPV Surgery Association will be within the EHPBA. It's going to be a process, of course, to join us, but at the end of it, I hope we can all celebrate that with those of you who will be able to come to Dublin in June 2025 to eventually join the community. So once again, welcome from the EHPBA. In particular, I bring you the salute of Professor Mark Besseling, who's a great friend of mine, and who is also welcoming you to Dublin 2025. So once again, thank you very much for your interest to join us. This is a great day, and once again, I will be more than happy to, in person, welcome you once we'll be able to meet in person. Thank you very much.
For your best wishes. Please wait online. I will introduce your chairman, and next they will introduce for your presentation. Okay? Açılış konuşmalarından sonra saygıdeğer meslektaşlarım, bilimsel toplantımızı başlatıyorum. İlk bölümümüzün oturum başkanları Sayın Mustafa Kerem Hocam ve Sayın Nuri Bayram Hocam. Onlar oturum yönetecekler. Buyurun hocam.
Birinci toplantımızın ilk bölümünü açıyorum. Siz. birinci konuşmacımız Giovanni Marchegiani, Avoda Üniversitesi HPB Cerrahisi Bölüm Başkanı. Aynı zamanda Avrupa Afrika HPB Derneği üyelikten ve genişlemekten sorumlu başkanı. Biraz önce kendisini dinledik. Şimdi konuşmalarını yapmak üzere tekrar bağlanacağız. Giovanni.
Sesi kapalı. Sesini görüntüsü kapalı şu an.
Can you hear me?
Yeah.
Perfect. So once again, thank you very much for the opportunity to present today regarding minimally invasive and robotic pancreatic surgery, which is the main topic of this event. So we decided with Professor Kerem to talk about one very important trial, which is called EUROPA trial, that basically started the new future of robotic pancreatic surgery in Europe. But we also have to be very careful and very aware of what we read when we have these pieces of evidence. Because what you would think if you read to this paper, which is published in Lancet in 2024 and comes from the biggest institution in Europe regarding pancreatic surgery, namely from Germany, Heidelberg and other centers, is that now we should all do robotic pancreatic surgery and robotic pancreatic. But we have also to be very careful because there are very important aspects that should be underlined, and they go beyond a title like this, which is a randomized controlled trial on robotic pancreatic versus open PB. And we all started this very important surgery, very difficult surgery, with an open approach. So what lies beyond this data? What lies beyond this title? Again, we are in the biggest institution in Europe, where they, and I physically visit that institution every year, they basically operate on around 10 patients every day on pancreatic surgery. So, can we export this data to our normal clinical practice? This is a very important question that we have to be very careful of. So, they decided to include all the suitable patients for pancreatic, both robotic and open, for any indication, but they decided to exclude all the borderline esophageal cancer and locally advanced cancer, according to NCCN. So once again, if we talk about robotic pancreatic and we talk about how to export this technique, we can only now have evidence regarding resectable tool. So in the next presentation, I will talk about minimally invasive pancreatic surgery and vascular resection. That's another chapter. But please remember that when we talk about robotic Whipple, we still have evidence only on the resectable cases. So in this trial, which is again the first step for the future of robotic surgery, they compared 40 open procedure and 40 robotic procedure. Once again, we have to stratify also the patients, but also the surgeons. How do you define a sufficient experience for a robotic surgeon? That's a very important question that should be answered also. The first endpoint of the study was the cumulative morbidity at 90 days, namely CCI. But you see that there has been also, as you can see here, a lot of secondary endpoints. Duration of surgery, blood loss, conversion rate, those are all very important targets when you start your program in robotic surgery. Also, you need to have pathological data to be compared, because of course you don't want to lower your standard of quality when you operate a patient with a robot compared to when you operate the same patient in open technique. Then there is the chapter of cost. How much is a robotic whip? Can we rely on cost for robotic people for every patient? That's also very important. Also we need, and this is very important, to talk about the surgeon's mental and workload stress. Because we all know that one of the shortcomings of laparoscopy is that surgeons and the ergonomics are very important, and we need also to lower down the stress on us as operators for very long hours of operation. And finally, last but not least, we have all the chapters of complication. We need safe operation for our patients, not only with the laparoscopy, but also with the robot. So all these questions will be answered by this trial, and I would like to have a discussion with you on basically all. Again, in this trial there has been a randomization, right? But of course, nor the participants nor the surgeons were blind. So this is not a double-blind controlled trial, and that's a very important factor to be taken into account. 81 patients were enrolled, and you see that they were either randomized into robotic or open procedure. Then, as some of the patients dropped out, in the end, the intention to treat analysis were between 29 patients who underwent robotic whipple and 33 who underwent the standard operation. The baseline characteristics of the modified intention to treat population were rightly balanced, and this is the main endpoint of the study, which was a CCI within 90 days, and not surprisingly, the outcome was reached, so there was not a significant difference between the two. When we go to intraoperative characteristics, you see that, not surprisingly, we had a slightly longer operation for the robotic whip. And this is an evidence. When you start your program with a robot, you know that the time of surgery will increase. This is normal. It belongs to the learning curve not only of the surgeon, but of the entire team. So it's expected to be like that. Then you will have slightly modification on your technique. For example, if you always preserve the pylorus, and then you start with the robotic whipple, you know that in most of the cases you won't be able to preserve the pylorus anymore. This is again a technical issue when you do the gastroenterology. I myself, when I started to do my first case, I tried to preserve the pylorus, but if you do for a whipple procedure with a robot, you know that this is faster. So most surgeons decide not to preserve the pylorus with the whipple. And then, if you apply drainless policies to your open case, be aware that with the robot, mostly all the whipple will have drains. And then you want to check your amylase to see whether you're going to have a fistula or not. But again, consider this when you start your robotic program, because there will be this modification within your cases. Then we have to talk about costs. There will be slides about that. But not surprisingly, the robotic whipple has higher costs for your hospital. So be ready to face this issue, because you will have to select at least some of the cases also for this reason. You also have to realize that at least at the beginning you will have higher complication, for example, delayed gastric emptying, which is, I would say, fairly rare for the open whipple. In this trial was only 6%, but when you start your robotic cases, you will have, at least at the beginning, an increase in the number of these complications. And this comes again with the modification of your technique, which will take time to adapt on your open whipple standard. This is again normal when you start your robotic whipple program. In terms of other factors like the ergonomic of the surgeon, this experimental study found that of course there is less stress on the surgeon, and the ergonomics on the robotic whipple is actually better for the surgeon, not surprisingly. And not surprisingly, also from the histopathology standpoint, there were no statistical difference between the two. So coming to the point, is it oncologically sound to operate with a robot? I already tell you, there is no debate. Yes, it is. There is no difference in terms of lymph node that you can get or in terms of final pathology for your operation, which is a great news. So we can discuss. We can friendly discuss or we can fight among colleagues whether we should all move to robotic surgery, whether we should select some case, others go into laparoscopy or remain with the robot. We will never have the answer. But the evidence is that not only the future, but the present is already a present of robotic surgery. This is a fact. This is something that we cannot avoid for the future generation of surgeons. But let's discuss some aspect of the trial. For example, the sample size. Do you think that 80 patients are enough to define if you can safely perform a robotic pancreatic duodenectomy? This is very questionable. It's very questionable because we have this very important factor, which is the learning curve. What do I mean with learning curve of a surgeon? I mean the very important process that you will have to again go through, even if you are an expert, open and laparoscopic surgeon, to get to master the technique of the robotic surgery. That's very important. You will have to do exercise, you will have to start with easy cases and then increase the difficulty of your cases to go through your learning curve. This is a key factor. You need at least 15 robotic surgery to start your feasibility phase. It has been published in Annals of Surgery that you need 62 procedures to reach proficiency. What does this mean? It means that your patients are not paying for your learning curve anymore, because you can have the same mobility with the robot than the one that you have in open. And finally, the last step is the mastery, which comes from almost 90, 100 robotic people, which means you reach your best outcome with the robot. So think yourself, how many cases do you need to really stand on the shoulders of giants, which means to reach the same outcome as in the other technique, or even better. You will need many cases to do so. Again, this is not a contraindication to do so, but this is a factor to be taken into account. Then you have this factor, the conversion rate. We surgeons are always very, let's say, skeptical and worried about conversion. Even in this trial, the conversion rate was high. 1 out of 4. It's a lot. It's actually a very high conversion rate. And what does it mean? It means that even in Heidelberg, when they were doing the trial, they were in their learning curve. In other experiences, you can see here, the conversion rate is as low as 6% or 5%. Those are the numbers you should aim at. So, an ideal conversion rate is around this 5-6%. In the trial, it was way higher. And it means that you should be very aware to run trial only when you already reached your proficiency level. Secondary endpoint, as I said, they specified that robotic surgery is safe, is already visible, but be always aware that pancreatic surgery is very unique. So you have outcome that will not change in open or with the robot. Because you have to stratify patients, you have to realize that the risk of having a fistula, for example, will never rely on the technique, but will rely on other factors. Which factors? For example, the pancreas. If you select your first cases with small tumor, if you will have soft parenchyma, small pancreatic duct, then you will have more fistula. So be aware to face this issue, because you will have, as in the trial, a different risk profile and probably higher fistula in your learning curve. It doesn't mean that you are a bad surgeon. It means that even with this new fantastic machine, you will have to deal with a risk of fistula, which is a risk of the pancreas and a risk of the patient. Finally, the cost. I was mentioning that starting this program is very expensive. Each robotic weapon in Europe will cost you 12 €8,000 more. It's $11,000 more. So this is a factor that you will have to face and take into account when you will move from the open laparoscopic case to robotic case. So the question is this effective? We don't know. It will be effective when the cost will be reduced and when this will impact on our patient. So again, after the learning curve and after the establishment of the program, robotic will be also cost effective. But right now, it's not the case. And finally, to be very open with you, my friend, and our community, we also need to take into account other factors, like the preference of the surgeon. We all like robotic surgery. We all love, this new tool. We all know technology, innovation, but we also need to be aware that we don't have to do this surgery only because others do the same surgery. Safety of patients come first. So myself, I always select the case for this technique, not to jeopardize my patient, because the safety of the patient is the most important factor, even more what we can achieve, and it's regarding the ego of the surgeon. So my conclusion is that it is not just the future, it is the present that is technology-based, and this trial for the first time in Europe and within our community showed that you can safely perform robotic whipple exactly as you perform the open cases. However, we are at the beginning of our story. It is still data coming from a single center. Patients are, of course, selected. And this is the most important factor. The learning curve, even in Heidelberg, was not completed yet. So it will take time to master this technique. But of course, in the long run, this technology will come at lower price, so they will become way more cost effective. There will be more systems available, and this will also decrease the cost. It is the future? Yes, it is the future. So welcome to all of us to the future. But we will need more data, more evidence to, first of all, be better doctors and better surgeons for our patients. My biggest thank is to Professor Mustafa Kerem, who is a great friend of mine, a very big friend of the Turkish chapter of HPB, and I look forward for future collaboration with all of you, thanks to this long-lasting friendship, and also thanks to the fact that you are a very vibrant community full of great surgeons, and you will play a major role within our community. And I would like to invite you all to Dublin, Ireland, June 10 to 12, to meet in person and gather for a fantastic EA-HPBA meeting in 2025. Once again, thank you very much for virtually having me, and forgive me for not being able to make it. But as you know, December is a bad month in terms of flu and COVID relapse, so I couldn't come in bad condition. Thank you very much.
Thank you for a great presentation. Below you too also. Thank you, my friend. So maybe we have some questions from audience. Soru var mı? Arkadaşlar sorusu olan var mı? Giovanni, I have a question for you. You know, the recent publication in JAMA surgery, the effect of pancreatic fistula after minimal invasive and open pancreatectomy. And this study showed that some problem, especially pancreatic fistula happen in minimal invasive pancreatic group, is worse than open group. What do you think about this study?
What I think, my friend, is that once again, you cannot think that you can decrease pancreatic fistula with a technique. I myself did several studies regarding which is the best technique to decrease a fistula, but the truth is that fistula relies on different factors which are pancreas-based. So I think that today the best way to deal with a fistula is to mitigate and prevent. So if you have a soft pancreas and a small duct, you should be able to perform your best anastomosis, whether it is pancreatigonostomy or pancreogastrostomy, to consider if you want to put stent, either internal or external, always to drain, and if you have available to do so, you can use octreotide and somatostatin, even though there are controversial data. But once again, 0% fistula does not exist and will never exist, and we have to stop thinking that there are technical factors implied in the fistula development. You know that there will always be fistula. The good pancreatic surgeon is the one who's able to mitigate a fistula when the pancreas is soft and the fistula will come. This is a truth that my master in surgery, Claudio Bassi, one of the most famous pancreatic surgeons in the world, taught me. And I think he was very right.
Okay, thank you, Giovanni. We are waiting for your second presentation today. Okay, stay with us. Thank you.
Thank you so much. See you later.